Good morning, everyone. I am Sitanshu Shekharkar. I work in the Department of Preventive and Social Medicine and a core faculty member in the Medical Education Unit in the Department of Medical Education in JIPMER, Pondicherry. It's my privilege to welcome you all for the 16th national webinar organized by the Department of Medical Education, JIPMER. And we started our journey in July when we hosted our first medical national webinar, and we have reached the 16th today. We are very grateful to have Professor Sarbadhikari with us, and I'll be introducing him in just 2 minutes. So the issue about today's webinar is very important. What we are going to talk in this 60 to 75 minutes is about healthcare is unique because it is associated with continually evolving and complex processes associated with health management and medical care. In this webinar, we'll learn various concepts regarding digital literacy and health data literacy. And currently, time is apt to prepare our health workforce to become proficient in data usage and become health data literate. So with this little background, I welcome you all to this national webinar on role of digital literacy and health data literacy by Professor Supendranath Sarbadhikari. So to introduce Sir is a physician and health informatics educationist regarded as a pioneer in spreading awareness of health informatics in India. He is an independent consultant for digital health standard and a global expert roster for digital health, World Health Organization. He is a visiting professor, Chitkara University, Chandigarh, Goa Institute of Management, Apollo Health Education and Research Foundation, and Foundation of Healthcare Technology Society, New Delhi. He has been a member of the Board of Governors, Health City University College of Medicine, St. Lucia from 2018-19. He is a distinguished fellow, HIT Lab, and I am an honorary professor. He is a founder member of HL7 FHIR Foundation. He has been Dean and Professor in the International Institute of Health Management Research, IHMR Delhi, from August 2017 to September 2018. He has been the Project Director, Center for Health Informatics, National Health Portal, Ministry of Health and Family Welfare, Government of India. He is also Founder Director of Suptan Institute. His CV goes along, like least if I start reading this CV, then probably will not have enough time to discuss the topic per se. But my association with Dr. Suptan goes back to 2012 when he was a faculty member in the PSG FEMA Regional Institute, and I joined there as a fellow. We have been in very good terms since then. We have been Facebook friends, and we have been connected digitally throughout this journey. So it's my privilege, and I'm very happy that I am there for you, sir, to discuss with you. And we welcome you to this national webinar. Now the floor is yours. You can share the slide and start the presentation. Before that, before I hand over the session to you, we have some ground rules for the participants. Please keep your mics mute. If you want to raise some questions, you give your comments, please write it in the chat box. We'll try to take questions from there. I know Professor Suptan very well. He wants the session to be very interactive. He will take questions in between if there are questions. So please feel free to post your comments, questions, or clarification in this during this interaction. Thank you so much. We welcome you, Professor Suptan, once again. And now the floor is yours. Over to you, sir.
Thank you very much, Dr. Sitanshu, for this excellent introduction. And as you rightly said, I would love to have questions. The only problem in this Zoom is that when I'm sharing the screen, actually the other parts are not visible. So feel free to interact. As I said, Dr. Sitanshu said you can put in the chat box so you can raise your hands.
Yeah, so we'll be monitoring the chat box. If there are questions, I'll point it to you, sir.
I'm sharing the screen, and I think we'll interact more without the PowerPoint. So this is just to have a sort of placeholder. So can you all see my screen?
Yes, we do.
Okay. So the topic looks very big, but let's try to break it down into smaller pieces. So I'll give an introduction, which may not be really brief, but will cover some area. Then I'll talk exactly, what do you mean by digital literacy? What is data literacy, particularly for health data? How can we apply it to medical education? So I'll be referring to certain case studies, things which have been going on globally. How can we integrate with the regular curriculum? Now, this is a tall task, and probably a lot more efforts are needed from each of us, but definitely things are moving that way. And question answer is not just for the last, as I said, you can interrupt me anytime, and I welcome questions in between also. So this is a document I think all of you know. This is the National Health Policy, the third edition that came out in 2017. And here you can see that it was clearly written that a National Digital Health Authority will be set up for facilitating a digital health ecosystem in India. Of course, the authority is yet to be set up, but meanwhile, other things have been happening. So we'll look at what are the other things which have been happening related to these. One of the things on which I think all of you are working is this MCI 2018 guidelines, which came that competency-based medical education. So one of the things, the goals for learner, section 2.3.2, says that the Indian medical graduate should be a leader and member of the healthcare team and system with capabilities to collect, analyze, synthesize, and communicate health data appropriately. This is really a very good pointer. Of course, we don't have more detailed breakup on this subsequently in the document, but this is a very important goal, and that the erstwhile Medical Council of India recognized it as really commendable. And it's now our duty to really make people go this pathway. This is something very basic. Whatever we observe, that's the raw data. Only when we put it in context, then it becomes an information. When we add meaning to it, we get knowledge. And wisdom comes through intuition or insight, often experience, time. That's what brings it. Not easy to go there, but this whole thing is a continuum. So from data, you process into information, then you process information. The art and science of processing information is also known as informatics. So through health informatics, you can process health information into health knowledge. It is the knowledge that really we use. That's what's tested. But of course, wisdom, as you saw, it's difficult to reach, but everyone looks forward to that. So in data, like you have just the facts, there's no pattern, no relation, no principle. But when you process it into information, then you get some description. What, who, when, where. Knowledge is really the instruction, the applied part, how to. But wisdom is really what is the best way to do it. Not just doing it, but doing it right. So if you go in the data analysis pathway, so initially you have got a lot of noise and misinformation. Then you try to get some useful data, superfluous data, then get into meaningful metrics, information. And as you go up the knowledge pyramid, you can then make models, predictive intelligence-based decision support, and so on. So that is how we are all trying to go ahead. And I think this COVID-19 pandemic has, again, pointed towards the awful inadequacy of our knowledge. And unless we have this knowledge, unless we have the data at the entry point, we cannot really generate the information or knowledge. And therefore, we cannot act in the best possible way. In fact, if you look at the information cycle, the cycle is collection, processing, analysis, presentation, interpretation, use, and you go back to collection. For each of the states, you really need to know what do you want. And then you decide how do you get it. So first, before you collect data, and this is what you can say data quality assurance. First, you need to know what is an essential data set that you need for the problem you're trying to solve. Once you decide what data set, then you have to make the definitions. You have to be very unambiguous in your definitions. Then you have to decide on the right tools which will be able to collect the data according to your definition. All these things need to be done very rigorously or meticulously. Sometimes we don't even bother about it. Oh, whatever data comes, we'll let us come and then we'll analyze. But that's not the right way to go ahead. So once you decide what to collect, how to collect, and that is what data literacy is all about, that we really need to know what do we need. Then you go into the processing part. There you have the quality reporting, what are the target populations. Then you get into the analysis part. For that, you can do self-assessment. You have various indicators and targets. Then comes the presentation part. In fact, today's lecture being more of a didactic one, I won't go into it, but the difference between the presentation and the next part, interpretation, that's a very important area where we often really get confused. So what is presented and what is interpreted, that depends on various factors. Presentation, we all do through tables, graphs, populations, maps, whatever. But interpretation, the comparison, trends, real epidemiological knowledge or wisdom, directly from the presentation, it's not always easy. In fact, one of the things which has been doing the rounds, again, with respect to the ongoing COVID-19 pandemic, is that all the countries globally, they have been actually using various types of presentations, statistical presentations, PowerPoint presentations, nice pictures, but the end result is quite, in fact, suboptimal, because again, the data that is needed is not there. So like in computer parlance, there's a term GIGO, garbage in, garbage out. So if the data itself is incorrect, incomplete, and then whatever we analysis we do and take an action based on that is not likely to be right. So after the interpretation, of course, the use part comes. As I said, I mean, the interpretation is not right because the data collection was not right. So whatever way we use is not right. And that's also seen because even till date, we really don't know exactly what are the triggers which leads to the severity of this disease. So if you think of the terms, as I said, informatics, so health informatics, where you're using data information and knowledge to improve the delivery of healthcare systems and also to improve the patient outcomes. And analytics is the actual analysis. So informatics is the application. So analytics is really a subset of informatics. Even before collection of data and information, we need to know really what's there. So informatics really spans before and after analytics. If we look at it, it's a broader way. Now, this is the National Digital Health Blueprint, which has come up in response to the National Health Policy, where it said we need to have a national digital health ecosystem. And this blueprint is actually quite well defined. I won't go into the details of it, but one of the things mentioned there is the National Digital Health Mission, which will be the administrative arm. So before going into that, if you look at the disruptions, what's happening in the COVID-19, so because of the lockdown and restrictions and so on, so one is the technology-wise, there have been robotic applications, including in healthcare. The other is education and healthcare. Both these sectors have been forced to go much more digital than was envisaged earlier. And this particular session, we are talking about education for the health professionals. So it's very pertinent that really a lot of digital disruption has happened even without our planning it. So digital health is being adopted because there's no other way. The Telemedicine Practice Guidelines 2020 has been released by the Ministry of the Health as well as the Ministry of Ayush, and it was notified in the Extraordinary Gazette in 14th May 2020. Then there are lots of mobile applications and dashboards to track and trace the progress of the patients. And as I said, the Prime Minister formally launched the National Digital Health Mission on 15th of August this year. This is the Gazette notification for the Telemedicine Practice Guidelines. and this is for the National Digital Health Mission. So one of the things which I hope, this is definitely an excellent first step, and we hope that the health outcomes of people of India will also improve through this interoperability-enabled digital health interventions. In fact, our Honorable Health Minister, Dr. Harshvardhan, had given a very explicit write-up in the Indian Express as an opinion piece that citizens' interest is at the core of the National Digital Health Mission's design, and it will radically change India's healthcare delivery landscape. When we are talking about digital health, again, the topic of the day. So the definition, what is digital literacy? Digital literacy is nothing but the individual's ability to find, evaluate, and compose information through writing and media on various digital platforms. And this was evaluated by the individual grammar, composition, typing skill, ability to produce text, images, and other things, application of media. So how to utilize the media, multimedia, is really what digital literacy is about. And what is data literacy? That's the ability to collect, manage, evaluate, and apply data in a critical manner. That's the most important thing. So in one of the definitions we find, read, work with, analyze, and argue with data. That's very important. Don't accept anything without questions. That's what data literacy is all about. So the third term, which is not there in the title of the talk, but it's very relevant, is the digital health literacy. And that's becoming also an essential component to utilize all this digital healthcare data for transforming it into actionable information and information-based policy making. Because the information that we have, the knowledge that we derive from this information that has been gathered from the data, if that is incorrect, then obviously the action, the policies will also be ineffective, which we are seeing time and again in the case of this COVID-19 pandemic. All the policies that are being taken by the governments all over the world are actually not working the way it should have. And the basic reason is because we still don't have enough data. We have not collected the right data, or we are not trying to get the right data to get into the right information knowledge for action, right policy making. This is one of the core things in digital health. If you look at it, an electronic health record is really a longitudinal record from birth to death for any individual. And how do you develop an EHR? It could be from multiple EMRs or electronic medical records. Those are episodic. When a person is admitted in a hospital, you can have an electronic medical record. Also, you can have a personal health record maintained by the persons. And now we are getting lots of information, personal information through the wearables, the Fitbits, the Apple Watch, and so on. So all this can go into the EHR. But of course, we don't really have a longitudinal EHR, but we need to start somewhere. And if you look at health informatics and public health informatics, what is added in public health is also the population informatics. That means the socioeconomic status, migration, education, employment, all these things would be added. So health is individual, but public health is for everyone. The ultimate aim is really to get all this information to make everyone healthy, every individual. And for this, as I said, it's again that information cycle you're getting from individual patients, then you're collating them into the records, the registries, then you're doing research and also developing standards, then creation of protocols, guidelines, and so on. Finally, it comes at the point of care. It comes back to the point of care so that individualized treatment or personalized treatment can be given. And most important thing is this health informatics is digital health is people. So it's not information technology alone, but it's the people that really makes what's there. Another very interesting thing which is happening, this healthcare is actually shifting from the bigger hospitals more towards the homes, or tele-home care is happening. And because of COVID, this has suddenly increased a lot. In fact, There are some statistics coming out that 500% increase in telemedicine practice during this COVID-19 pandemic. If you look at it, the cost of care and the quality of life is much higher and the cost is much less if you are staying at home. Whereas if you're going in a multi-specialty hospital or tertiary care center, the cost of care increases manifold, but the quality of life doesn't really increase to that level. So that's a very important thing, why this thing is happening. And because of the technology now that is available, digital health is coming in a big way through multiple interventions, through the smartphones, through the Internet of Things or Internet of Medical Things, as I said, of the wearables, Fitbit, Apple Watch, and so on. All these things generate a lot of user information, health information from the individual. This is another term I think all of you would have heard of, big data. Now, one of the things in the formal definition of big data is really more of a minimal structured. I mean, it's really any data from anywhere can get into it. And so that becomes really very difficult to put in one place and analyze. This is a global survey made by PwC in 2016. And here, as you can see, globally, all over the world, people are actually going for more and more of these wearable devices, different types of sensors, counting the calories, counting the steps, counting your heartbeat, and so on. So various types of things people are going, accepting and adopting this. And what's the fallout? When they come to a doctor with some problem, they expect the doctor also to give the treatment, management, based on the information that they have collected from these devices, which they're wearing, which are at home. And many times, even the doctors, the healthcare professionals are quite at sea, because first of all, the volume of the data is huge. And then often you do not really know which part of the data is useful and which can be really analyzed for management, for better health outcomes of that individual. And that is where, again, health data literacy comes in a big way. So there are various work going on globally in various places. So here, just two departments in Stanford University, Oncology and Neuroscience. What are they saying? In oncology, in Stanford, they're saying on the more clinical side, there's been a proliferation recently of national cancer registry-based studies that analyze data from tens or hundreds of thousands of patients. And that also has let us ask some questions that we could never have asked with prospective studies. So this is something very important. We are already having a lot of data. We don't need to really calculate a sample size and do a sample analysis. We can get the whole data and analyze it. Computational power, information technology is available for that. And they are giving rise to new insights from the data which is already available all around. So similarly for neuroscience also, they have been saying there have been exciting developments because the sort of information and knowledge that is now available from so many sources, and they can be analyzed and they can be then used for various management protocols. This is one good article on, it's a systematic review and conceptual framework for health literacy training and health professional education. And this, as you can see, is a rather fairly recent, less than 3 years old. And all these references are there in the presentation, and I'm sure that you can get a copy of the presentation. You can have a look at this references. This is an open access article. You can get the article and go through it. I'm not going into the details of it, but lots of things are happening. And what is most important, that this is an underdeveloped domain. When we talk about health literacy, in fact, healthcare professionals or healthcare professional educators also need a much better understanding of the impact of health literacy training on specific students. And over what time. So when we talk about targeted curriculum, workforce education planning, health literacy is a component that needs to be taken in a big way. And as I said, another very important component now that's come up is the health data literacy. I mean, what sort of data is really useful? What data should we collect? How should we collect? And then we can get the information and knowledge based on which we can do real effective action. So that's a very important area where we need to do our work. This is one of the examples, I've taken from one of the courses, which is available on data literacy education. So if you can look into it, the topics, the conceptual framework, data collection, data management, data evaluation, data application, for each of this, you have various theoretical part, but more important is the tools. And as you can see, for data application, it's the data critical thinking, data culture, data ethics, data citation, data sharing. All these things are important. Each of these topics actually are developing into full areas for study. And we really need to look at it because knowledge synthesis is not easy. In fact, if you look at it, right now, the doubling time for medical education is about 72 days. Just imagine, all the medical knowledge around us are doubling in just about 2.5 months. And it's humanly impossible for anyone to keep track of all the new knowledge, even in their own field. And so we definitely need to be more data literate. We need to know exactly what is needed for us to function well and what is good for the individuals, also the patients. This is one course on healthcare data literacy from the UC Davis. It's available in Coursera. So when I had taken the screenshot, it was just about to start. It was starting on October 29th. So right now it's ongoing. But then there are various courses like this which come on. And I think probably each of us can go and join such courses. These are MOOCs, the massive open online courses. And this is from UC Davis, California, University of California, Davis. And there are various other courses also available. And I think it's worth exploring. Then we can get an idea exactly what is healthcare data literacy and how can we go ahead with it. So I'll wind up the presentation part and then we'll open it for discussion without the presentation. So essentially, what do we need? First, we need to have a health data literature culture starting from the top. Because our human nature is like that. Unless the head of the institution is interested in anything, others are even less interested. There are exceptions, but in general, that's how it works. So data visualization and user experience. I mean, just having data is not enough. We need to understand what is it. So visualizing and understanding it. Then modeling, healthcare data models. Then healthcare data quality and governance. These things are also very important, as I've explained some of those. Then we also need to work on analytic solutions to common healthcare problems. So individuals have to embrace their own weaknesses and the gaps in the ability in the data literacy, that is the ability to read, work with, analyze, and argue with data. Now, how do we integrate with the ongoing curriculum? Of course, curriculum in our country, it has to come from the top, the MCI, or now the NMC has to give it. But essentially what we need is, we need to foster transdisciplinary participation and research. So data scientists, statisticians, librarians, that is the information scientists, all these need to come together to really think how best we can train it and also how to evaluate what are the best practices in these efforts. And this is how we can go ahead with it. So I think I'll stop sharing here and then we can interact. So over to you, Dr. Sitanshu. We can go into the question answer part.
Thank you so much, sir. Can you hear me?
Yeah, sure. Go ahead.
So thank you for that lucid presentation and very nice introduction to the topic. And it was really, it set the ball rolling. So probably we'll take some comments or questions. Let me look at the chat box, then I'll come back to you, sir. Okay, so we have got one question where the participant is telling that he liked the presentation. Thank you for the nice inputs. Like NMC adopted telemedicine in the form of guidelines. Which body is expected to declare digital health guidelines for physician? Anybody, anything that you can suggest about that, sir?
That's Ajay showed in the National Health Policy 2017. It said that there should be a National Digital Health Authority. So the process was actually started for this. So there was a bill drafted for it, and in fact, I had been actively involved with that. So that bill was named the DISHA, the Digital Information Security and Healthcare Act. So this DISHA bill was drafted and it was put in the public domain for comments during March, April 2018. And I think many of you might have also sent comments for that. Subsequently, it was put in the parliament, the DISHA bill. But what happened later, the B.N. Sri Krishna Commission came out with a data privacy policy. So they had been working on it, and then that was enacted into a bill. I mean, that was drafted into a bill that's called the PDP bill, the Personal Data Protection Bill, the PDP bill 2019. The Personal Data Protection Bill 2019 was put to the parliament last year. And subsequently, it was sent to a joint parliamentary committee, which had again asked for comments from all the stakeholders. Currently, the joint parliamentary committee is actually examining those, and they have also been calling all the stakeholders, including the big players, Facebook, Google, everyone is coming to them for, I mean, the data privacy policy. In fact, the National Health Authority also set up health data management policy. That was also there for public comments for quite some time. So they're trying to work on it. The Personal Data Protection Bill, now what happened, there was a parliament question and it was mentioned in the parliament by the Minister of State for Health that the DISHA bill has been withdrawn in favor of the PDP bill that will subsume it. So Personal Data Protection Bill is about any data. Healthcare is one subset of it, will be covered by it. So once the PDP bill, that becomes the PDP Act 2020 or whatever, then it will be giving the guidelines. But we definitely need, I think, something like, we have a Telecom Regulatory Authority of India. So similarly, we do need the National Digital Health Authority, which will really come up with the guidelines. Till then, of course, the Ministry of Health and Family Welfare, Niti Aayog, and National Health Authority and so on, they are the ones who would be giving the guidelines. Because National Health Authority is also the nodal agency for implementing the National Digital Health Mission right now.
Right. Thank you. Thank you so much for that response, sir. Before I take up further questions from the chat box, if I may ask a question to you, sir.
Yeah, most welcome.
So you have been working and engaged with such national level initiatives for quite a long period now. So if you would like to share some of your challenges or the wow moment, aha moment for you, for us, so that will be nice to hear from your side, sir.
Yeah, I think thanks for poking me into talking the areas of my interest. Actually, I've been working in the standards for health information exchange for more than a decade now. And I've been involved with, so the standard for clinical and administrative data transfer is the HL7. So I've been a chair of HL7 India during 2011 to 13. And another standard for this vocabulary or the terminology is SNOMED City. So I've been an international expert for the e-learning advisory group in SNOMED City from 2015 to 18. So I've been actively involved with it, and I am also involved with the Bureau of Indian Standards in the Health Informatics Committee, MHD 17. I am also the chair of another committee with BIS that's for active assisted living. So how do you really develop standards for equipment which can help in active assisted living for people, elderly people, as well as disabled people, how we can really go ahead. So those are the things we have been working on. So what happened, we had been working on the standards, and the first edition of the standards for EHR was notified by the Ministry of Health way back in August 2013. Subsequently, India became a member of SNOMED City in March 2014. And then that was revised. So the second edition of the EHR standards came out in December 2016. After that, what has happened? The National Health Policy came out in 2017. And if you say the aha moment, I think that is really good. The National Health Policy 2017 was the third edition. If you all remember, the first edition came out in 87. 15 years later, the second edition came in 2002. Another 15 years later, we have the third edition in 2017. which is talking about the National Digital Health Authority. So that's a welcome step, and I think it needs to be done. So I think the Personal Data Protection Authority may not be enough to look at the digital health data, because there's a lot of inherent complexity in healthcare, which, I mean, digital data for financial transactions or for travel transactions are much simpler, much more linear. Whereas when we come to healthcare, a lot of other things are involved. So anyway, those are policy decisions. But as I said, National Health Policy 2017 was very good. And subsequently, we had this National Digital Health Blueprint that was released in November 2019. That's last year, about a year back. And that is also a very comprehensive document. So even if the National Digital Health Blueprint is followed, it's a very good thing to do. Now, how do you go for this adoption? See, there are two ways of it. One is a top-down approach. That means you need to have a legal mandate, which we don't have as of yet in our country. So legally, it's not necessary to go digital. So the first thing which came in the legal way is the telemedicine practice guidelines, which came out in March 2020. And as I said, it is now notified in the Gazette in 14 May 2020. So telemedicine is now legally allowed. And the other thing, which is very good thing, and that is a doctor anywhere in India can actually do telemedicine. So if you look at the erstwhile Medical Council of India, you had the state medical councils, and most of the states actually insist that if you're working there or practicing there, you need to register again and again. So many doctors in India have got registration in multiple states. They still don't really have an effective central register and then the permission, but this telemedicine practice guidelines allows a doctor anywhere in India to attend to patients anywhere else in India. So that's a welcome step. So which is a corollary, but it's good, it's happened. So digital health, what has happened? Meanwhile, the World Health Organization, they have started the Division of Digital Health in February 2019. And the good thing is that it is being headed by the first chief scientist of WHO, that's Dr. Soma Swaminathan. So we can be very much proud of that. So she's looking after that. And so they are coming out with a global strategy for digital health 2020 to 2025. So within that, there, of course, as a part of it, as I said, I'm also a member of the roster for digital health, and we have a digital health technical advisory group. So a lot of things, digital health interventions, the framework have come out. Then we are also trying to put policies, and obviously, I mean, the way the UN agencies work, all the countries, there has to be country-specific measures. India, with a population of 1.38 billion, if anything works here, it can work anywhere else. So the scale is a big challenge for us, but definitely I think we need to go. But that's, as I said, these are all the top-down approaches. But the other is the bottom-up approach. So users are demanding. Now, in fact, it's a global village. So a person may be migrating within the country or beyond the country, different countries, different continents. Then they would say, if I can't access my health records from anywhere in the world, I won't come to you. Then obviously the healthcare providers have to assure that there's a sort of digitally accessible health records. So I think that is going to come sooner. And in fact, this COVID-19 is being called as the Chief Transformation Officer, which has really done a digital disruption in a big way. And as I said, health and education are the two sectors which have been impacted probably mostly because the others have already been taking digital means to do their business. But I think health and education, they have been definitely being forced to, and I think a lot of these changes are irreversible. So we would never go back to the pre-corona era. That's
so. Thank you for sharing those insight into those achievements. The one, if I may ask you, the challenges that you faced.
Challenges are, challenges go on increasing. In fact, George Bernard Shaw had said, science is never right. It always creates 10 more problems when solving one. Right. So that's always there. I think we are getting more questions in the chat box. Dr. Ravi Modali has asked a question, I can see.
Yeah. So now the question, the next one is, there are many participants like the presentation, and one of the participants asking, are there any course on this Swayam platform?
No, right now I don't think there is. But as I said, because the digital world is really seamless. So you can go to Coursera, edX, and like I showed that UC Davis course, there are courses like that, and lots are coming up. In fact, even I also do take classes on that. In fact, recently I had given one in AIIMS Kollam area. In last November, I had been in AIIMS Jodhpur making workshops on this. So I also do offer. But what is more needed, as I said, I mean, it has to be incorporated in the curriculum. I mean, back in 2004, actually, I was invited to write an article in the Indian Journal of Physiology and Pharmacology about integrating medical informatics in the curriculum. We are still not there. Although, as I said, I mean, the National Health Policy third edition is certainly encouraged it. And now with the pandemic and the National Digital Health Mission there, things are moving very fast.
Right, right. So there is another question about artificial intelligence. So they want to know, can you throw some light on artificial intelligence incorporation along with telecommunication?
Yes, so that's a very good question. In fact, it's an inevitable thing. In fact, I had a publication recently. In fact, anyone who's interested, you can get the link from me. It's an open access article. So where I have talked about this artificial intelligence and other technology, healthcare, technology-enabled healthcare delivery, and the ethical issues, because I think that's a very important area. So there are three parts to it. First is, of course, whether you can do the education part ethically. I mean, there have been lots of issues. We know, I mean, education, although the curriculum that is followed is the same, but it's not really imparted the same way in different institutions. So different institutions do it differently, and some gain, some don't. So ethically providing education is the first part. And obviously, when we talk about artificial intelligence, it's even more important. Then second part is developing interventions, technology-enabled interventions or AI-enabled interventions or machine learning-enabled interventions. That has to be developed ethically. That's very important. Because often we are enamored by the technology and don't think of the consequences. What will happen if it's done this way? Will it really be good for everyone or good for some people and bad for more people? Then the third part is, even if it's developed ethically, whether it's being used ethically or not. Like science, it's always said, I mean, it's a double-edged sword. So you can use it for good purpose, you can use it for not so good purpose. So all the three aspects need to be known. So whether we are teaching ethically, whether we are developing the technology-enabled solutions ethically, and if we have something like that, are we using them ethically? So all these three aspects have to be looked at.
Right. So just to take that question forward, is there anything related to AI in India currently in pipeline? That's the second part of the question that they
lots of things are going on. In fact, there are lots of medical chatbots now commercially available. In fact, there are lots of systems. If you look at Facebook and more so at LinkedIn, actually, there are lots of things on that. And in fact, even government is also encouraging that. There have been hackathons from the Niti Aayog as well as the NITI on these various things. Even during COVID-19, there was a lot of prizes given for that. How much is good, how much is bad? Again, that question comes in, because Arogya Satyu app is one of the most highly touted one, and which has been downloaded by crores of people. But again, data security is in question there, because the data policies, the different government agencies are saying different things. So if you don't really know what's happening with the data, who's getting access to that, and how are they going to use it? Right. So we badly need the PDP bill very soon, and particularly for healthcare, because in healthcare, as I said, I mean, it's a very, very important data which may deal with life and death. Right. So it's very sensitive. It's highly sensitive data, and we definitely need to have proper, not just policies, but implementation. Right. Whatever is written in the policies, those checks and balances should be in place in reality, which is not happening. Because if we look at the policy documents, we'll see everything is written well, fine, but it's not being followed. That's the thing we need to really look at. And that again brings back to the topic, unless we are health data literate, we won't know of the pitfalls. We won't know of what are the problems, what are the dangers. And if we don't know, how can we prevent it? Once we know, then we can think, oh, this can cause harm. So we need to prevent that. Like, I think if you have noted that, I mean, globally, when well-known system like the NHS of UK had a massive attack for ransomware about a year back. And most of the times what happens is because of our own negligence. I mean, we don't take this security issue seriously. I mean, a doctor's password is shared with various people, and so anyone can literally log into the system and do whatever they like. So those are not the way. So if we don't take care of the security ourselves, then I mean, how can we say if there's a breach?
Right. So let's come back to our MBBS curriculum. So there is a question that is being asked in the chat box saying that what should be the core contents of digital literacy for inclusion in MBBS curriculum? What are your thoughts on that, sir?
As I said, I mean, rightly the MCI competency-based medical education, the framework 2018, what they said, I mean, that goal 2.3.2. If we look at this, that itself should be the core. Now, how and when we are going to put it? See, one of the easier ways is if we really have anywhere where health professional education is done, if we have a standards compliant EHR system, then everyone would be forced to use it, the students as well as the faculty. So I think some amount of that top down, some legislation, some mandatory things are required. Otherwise, things will go their own way. And like in the US, what happened? Everyone did their own way. So there's no interoperability. They're not talking to each other. So now they had to spend literally billions of dollars to make the systems talk to each other. So we were in a better way that we have already notified standards. Now we need to follow it. So whatever digital system is developed anywhere, as long as they're standards compliant, these migration issues won't be there. And that would be the right thing. So we need to know really what we need. So I think that CBME, the 2.3.2, that's a very good, very well-written statement. That goal itself, and that's the core. We should definitely go by it and try to see how we can spread it throughout. I mean, it's not just for first year or interns or house staff or like that. It's for everyone, from teachers and students.
Yeah, thank you for that response, sir. So there is another question on which segment of health industry will drive adoption of digital health, either physicians, hospitals, regulators, insurance, or digital health companies. So your thoughts?
I told you, I mean, it's ultimately it has to be all the stakeholders, and biggest is always the user demand. When the individual people will come and say, if I can't access my record from anywhere, I'm not going to come to you at all. So whichever doctor, whichever hospital is doing that, they have to have a standards compliant system. Otherwise, that won't happen. I mean, if you look at it in another field, I mean, this is nothing new. Almost 10, 15 years that's going on. Even right now in India, there are various villages, very remote places where there's no electricity or people are not literate, but still they have been using Bluetooth for exchanging songs and pictures. Why? Because they find it useful. So it's a value addition that's the most important. Unless someone finds it useful, they won't use it. But if they find, yeah, that's working. In fact, that's exactly what's happened with telemedicine as well. Because of the forced adoption due to this COVID-19 pandemic, people are now finding that it's actually more convenient, and many of the things can be done without going to the hospital and standing in lines.
Right. So there is, after this, there are multiple messages saying that they liked your presentation. It was a very informative one, and thank you so much for your lucid presentation, sir. There is one question on how to motivate students and to understand the importance of data reporting. So there is a big, but I just told you the gist of the question. So how do you, the end users or the people who are generating data, how to go about that?
Yeah, actually, that is very important. Just a minute.
Yes. Please do send your questions in the chat box. We'll take it up once Dr. Supten is available. So it appears to me that there is a lot of interest that has been generated by this webinar, and the context and the issues that were being raised by Professor Supten. Yeah. We should all go back and try to read more about this thing. Yeah. So
I'm here back. Yeah, just what was the question? I just.
The question is how to motivate students to understand the importance of data.
Very good. see, what's the, I said, I mean, if we have a system, because as long as that is not there, if we are doing it in pen and paper, and then when they go and join in the hospital, most of the private hospitals have some sort of a digital system. And then they're basically starting from the beginning. So right in the training, I think that EHR, standards compliant EHR system should be a part of any health professional education setup. That's what I personally feel. The other thing which is there is the value addition. I mean, whoever is entering the data must get back some insight from the data that was done. So once the analysis is done, you get that. And if you go and do this, then actually you will benefit the patient. Then they would be very interested, because right now that value addition is missing. I mean, why should I mean, forget the other things, the time constraints or other things. But the moment I see that if I do it actually, and same for clinical decision support systems also, very alerts, there are sometimes drug-to-drug interactions or drug-food interactions, and an alert comes up, and then that could be a life-saving thing. Sometimes we often miss. In fact, many of the medical errors which happen are because systemic errors. And most of the systemic errors can actually be avoided by such digital systems. So these are the things. I mean, we need to see something that's happening, something good, that's something useful for myself, something useful for my patient. Then they would be interested. But as long as it's a theoretical talk, I mean, no one bothers. The other thing is, of course, it's a part of the exam, so we have to mug it up. But then mugging it up won't help.
Yeah, as they say, assessment drives learning. So
exactly,
put the question in the exam paper, they'll read more about it. Yeah. So to take the question and answer session forward, is there any external resources that we can refer for further understanding and exploring this topic? I think you have already given them the link.
Yeah, you can share my presentation. In fact, there are lots of references given at the end. And of course, Google is there.
Yeah. So anyone
so just ask Google, and you'll get a list of this.
Right. Right. So the other questions are: does implementation of digital literacy increase the documentation of patient by doctors? Is it going to increase the documentation process? Probably that's the question someone is asking.
Yeah, documentation is not really digital what's driving it. So what's happening, because in India also now the insurance is coming in a big way, health insurance. In fact, in US, that's a problem. It's the insurance-driven healthcare, not anyone else driven. So the documentation is more often than not asked by them, or sometimes by government agencies. But documentation doesn't mean that you have to go on typing each and everything. There's now technology available, even by, in fact, there are lots of excellent voice capturing devices available now. In fact, natural language, there are also pens available, which you can write with that, but it will be digitally entered and goes in. So technology is already there. But documentation, as I said, I mean, documentation as a legal requirement is something different. But documentation which can help in better patient outcomes, better health outcomes, that should be welcome. And that is, as I said, I mean, if we have more information, we can get more knowledge, we can do better action, better management of whatever we are treating. So we should look at it as value addition rather than as a burden.
Right. So another question is, what is your opinion on using social media for fostering digital literacy among medicals?
That is very essential, and that's going on. In fact, if you look at it in many advanced countries, it's being done in a big way, and even many patient self-help groups are also there in various social media platforms. Of course, there's always a risk. I mean, again, that privacy security concern. I mean, but then, I mean, you don't. I mean, no pain, no gain.
Yeah.
So you lose something, you gain something. That has to be there. The balance has to be found out. But social media is definitely being used in a big way.
Right. So one question is there about the accessibility or ethical issues related to it. What about the population which is having difficulty in accessing digital framework? How are they reached in these extraneous circumstances? So what is your take on this? We are experiencing some network issues at Dr. Suptan's. Professor Suptan is back. Yeah. So the question that we are discussing when there is a break in the connection was, what will be the issues pertaining to people who do not have access to digital framework? They're in remote areas. How do we provide them equal opportunity?
Yeah. So network connectivity is an issue, but I think right now even in remote places, we do have, if not smartphones, at least feature phones, which are working even on 2G. On the other hand, if you look at technology, I mean, 5G is also coming in India. It's just around the corner. If you look at the connectivity, we have now the optical fiber network that has been laid up to the Andaman Islands, Andaman Islands. So definitely connectivity is improving, but then where it's not possible, even for the National Digital Health Mission that's being done, that they're also doing offline things. So they're having, whenever there's connectivity, it can be synchronized. So sometimes we can use that store and forward method. If it's not possible, but I think connectivity is improving and it will go on improving day by day.
Right. As informed by Dr. Jayaprakash, this the YouTube link will be made available by to all the participants, and it will be available in our JIPMER website for information. So that's for because some people are asking about that. So we just wanted to let the group know about this. One more question is regarding.
I can also share my presentation, so you can just.
We'll do that. Whether we'll try to establish a reference interval for lab tests using big data from National Health Database. Any thoughts on that, sir? Dr. Jayachandran is asking that question.
The short answer is yes, but it's a long way to go. I mean, everything won't happen all at once. Lots of steps are involved.
Yeah.
So, but I think, as I said, this COVID-19 pandemic has given us the start. The digital disruption is there, and we should leverage on this rather than, wait for other things. But of course, legal mandate. That's definitely essential. And then also education. We definitely need to relook, because as I said, our knowledge doubling time is now 72 days.
Yeah.
2020. So in 72 days, if the medical knowledge is doubling, we definitely have to go digital. There's no way out.
That's true. So probably we are just completed around 65 minutes of our interaction. If you are okay, then we'll take one or two more questions.
Yeah, sure. And in between, we also have the technical glitch, connectivity loss. So everything is happening as it is. So real life.
So it's a practical demonstration of how digital world sometimes works. But 95% of time it is effective. It is very useful. We don't have to travel to listen to you. It is so interesting.
In fact, I was asked for this trial run, but I told trial runs always run well. You never have any glitches. But the moment you come into the real thing, there's always a problem.
Right,
even today it happened.
Yes,
so
yes.
Don't trust the trial runs. Trial runs
the trial run were fantastic. So before that, so there is one question on still majority of rural government. We have discussed this issue, but little further clarification maybe. Still majority of rural government hospitals and some private health facilities do not maintain e-health record. With this huge gap, how can we go forward with higher technologies and innovations?
Yeah, I think this National Digital Health Mission is really trying to plug that gap. So although it is being done by the National Health Authority, which is looking at the insurance part, but at least it's a good start. So personal health records, person-centered electronic health records, that's being made as a part of NDHM, and I'm sure it will go on increasing, because once people find the value, that's the most important thing. User adoption will come through that. If I have my data accessible from anywhere, then obviously I would be interested to insist on that rather than, carry those bagfuls of paper records and so on.
Right. So in your, I think that's the last question that we got from the chat box. But I have a single point to get some clarification from you, sir. You mentioned in your presentation on there is Internet of Things. So it is coming up in a big way. And do we have a repository from where, if you want to see the innovations that have worked, or some systematic documentation process for Internet of Things available in India? Or what are is it that the committees they are going to think about this, or will it be helpful?
No, I'm not aware of any such formal process. But what's happening is, again, like any devices, like mobile also. If you think of the mobile technology, most of the time you didn't go to any committee or website to search whether a mobile works or not. Your friend told, this mobile is good. Okay, you are using, I'm also going to use it. So that's how really the word of mouth really spreads it. So IoT is also coming in big way in many ways. Bigger companies obviously have bigger, like If you have this Apple Watch, now Titan Watch is also planning to come up with those health accessories and so on. So we'll definitely have, and obviously they would be doing their own advertisement, and we'll see them all around in all media publicity. But the other thing is, I mean, which works and which doesn't work will really be from personal experiences, and also, of course, from the hospitals. And they would say, okay, if you would have this, these systems are compatible. But if you have a standards-enabled ecosystem, then that also would be relevant. Whichever brand you use, as long as it's standards compliant, it will work.
Right. So as we are discussing this, there is another question that popped up in the chat box. I hope you will not mind taking that. So despite the promise of speech recognition, digital documentation is still dependent on typing data in. So is it not that a glitch to the digital literacy? So that's what the question is.
Yeah, no, it's not true, because now the speech recognition has really reached a level where it's as good as writing. And as I said, there are also pens, multiple pens available, which capture the data digitally. So you can write like a pen, ordinary pen, but actually everything would be stored digitally. You don't have to type the data to get in. So lots of technology. Technology is not the problem. The problem is, as I said, I mean,
user
facilitating environment. And as I said, I mean, because the head of the institute, the culture, right from the top, if the so some particular institutes or hospitals may be more tech savvy. In fact, many hospitals are starting digital, where they don't have any paper records or X-ray plates or anything like that. But whereas the older system, migration is always painful. I mean, whenever you're migrating from some older system to a newer system, it's painful. But when you're starting afresh, you can always have many of those things.
Yeah. Migration is always painful, as you rightly said, be it physical or digital. So it's the same thing. Right. Whenever you move. So I think we'll stop the questions here, sir. Thank you so much for your time, and we really enjoyed the session.
I think there's another chat question come on about the guidelines. Guidelines, the National Digital Health Blueprint. So if you just do a Google, or you can mail me, the document is available. You can just have a look at the National Digital Health Blueprint and all these guidelines. What are the standards required? They're explicitly given there.
Right. So in this last almost 70 minutes, we discussed the national frameworks, and you also very nicely told us the difference between data, information, knowledge, and wisdom. Though our objective is to reach to the wisdom level, sometimes it will take some time to reach there. The National Digital Health Mission, the digital literacy, the definition, and the issues pertaining to that, and how we should move from EHR to the personal health records, the need of the different health data literacy culture creation in institution. How can we integrate this into our curriculum? And as the MCI has very nicely given the guidelines in the GMER 2018 document. So the session was very well received, sir, and it was really a great learning for me as well personally. And it's always a pleasure to listen to you and discuss with you. Thank you so much for your time, and we hope we'll continue this association in future as well.
It's my pleasure as well, and thanks to everyone. Bye. Take care.
Thank you. We stop the meeting now, and there will be a feedback form that will be circulated to your emails. We had got around 200 participants logged in, though 360 registered. So they will get this email for filling up their feedback, and we take the feedbacks very seriously. So kindly spare some time from your busy schedule to give us feedback for improvement. Thank you so much on the behalf of the medical education team and the unit, Dr. Jayaprakash, the head of the medical education unit from JIPMER. We thank Professor Supten for his time, and thank all the participants for their active participation and excellent questions and excellent discussions that we had. Thank you so much, sir.